Hi everyone. First, I want to thank you the opportunity for me to share with you the recent progress of the non-invasive hemodynamic monitoring in the ER. First, I have no conflict of interest. So today I'm going to share with you first the philosophy, followed by the new evidence. Then we're going to share with you the recent progress in terms of the process-specific monitoring and patient-specific approach, and lastly, the machine learning approach. So the philosophy of hemodynamic monitoring. First, we have to define the cardiovascular insufficiency. It's often defined as the normal return of normal end organ functions such as SCL2, VL2, SDL2, etc. Then we know that the excessive fluid beds and inotropic can help. And but how can we help this? Is to use the dynamic variable instead of static variable, and there is some debate exists such as degree invasiveness, the frequency of monitoring, how to balance cost effectiveness, artifact, and accuracy. So what's new in hemodynamic monitoring? I'm going to focus on blood pressure monitoring, cardiac output monitoring, and the prediction of acute hypotension episodes with machine learning methods. So first is the blood pressure monitoring. Here I just listed the three recent studies. First is try to compare with the conventional oscillometry versus the intra-arterial measurement for the blood pressure. As you can see in this blind outcome plots, the mean difference is 13 millimeter mercury, and the range of limits of agreement is pretty wide. In terms of the concordance rates, for those can detect mean arterial pressure less than 60, is only 64%. So the preliminary verdict is this is a suboptimal methods. Then there's one study compared the brachial oscillometry versus the aorta blood pressure, and this is a systematic review without a formal meta-analysis. So they pool the absolute difference with only sample size as weights, which is not standard method for meta-analysis. They concluded that for systolic blood pressure, there is about 4 millimeter mercury difference, and for mean arterial pressure, it's very little. So it's feasible to use brachial oscillometry instead of use the aortic pressure. The last one is the very new one, is the PPG plus finger cuff. They compare with the intra-arterial pressure, and they did that in among patients with underwent surgery, and they found a very little mean difference, only -1 millimeter per mercury, and the degree of the agreement is pretty good. So the verdict is acceptable. Then let's take a look at the cardiac output monitoring. The first one is the transthoracic ultrasound, and the gold standard is all the pulmonary arterial thermal dilution. So only one study is old study, and it's published in 2005. In that study, it actually found the best mean difference between the method. This is actually a semi-automatic methods. So the other methods is actually published recently in the same study with the same population, and the mean difference of cardiac output is 0.7 liter per minute, and the error rate is about 40%. In terms of the concordance rate, interestingly, used the change more than 10%, possibly could be used for some interventions such as the leg rest test, and the concordance rate is no more than 50%. So I would say these are feasible, but not a perfect method. How about the newer methods such as the post-wave analysis plus finger cuff? They compare with, again, the gold standard, the pulmonary arterial thermal dilution. They found a pretty good mean difference, which is only minus 0.2 liter per minute, in a relatively larger sample size, and the degree of limitation agreement is acceptable, and the change concordance rate is pretty good. Lastly is electrical cardiometry. So this is again as a systematic review and meta-analysis. They concluded from 620 patients from 11 studies, although the references varied, but the mean difference is pretty good. However, they didn't use any concordance rate in this study. So I would say the last two methods is relatively stable and acceptable. Then let's take a look at the recent progress of the prediction of acute hypertension episodes using machine learning methods. First is most of the study, they define acute hypotension episode with more than 30 minutes at the mean arterial pressure less than 60 millimeter mercury, and they define it as 90% of the time. So the last bottom line is the accuracy is ranged very widely from 70% to 96%. So it's often is related to how you conducted this study. For a study with higher prevalence of the acute hypotension episode, that might influence the accuracy to be deviated to the better proportion. And they also have various machine learning model and feature extraction model. So in the right-hand side is the different machine learning model they use. As you can see, the best one is the LSH, which is actually the variant of the nearest neighbor methods. So these two methods are actually very similar, and they occupy the top two accurate models. Followed by some traditional models such as logistic regression, support vector machine, or k-nearest neighbor, decision tree, etc. And the estimation metrics also varies. So on the other hand, these are not really concluded the estimates of the performance of machine learning in this utilization. So still lots of study needed to be done. Then let's take a look at the process-specific monitoring or non-specific prevention. First, we're going to talk about the perioperation, then we're going to talk about the goal-directed therapy using hemodynamic monitoring. So, in a very old study published in 1993, they used SpO2 monitoring in the operating room, and they found it's not beneficial, although the experimental arm has more episodes found, but it's not influencing the outcome. So most of the study concluded that the current monitoring is mandatory without any validation, especially in the OR. So in 2018, there's a trial called the POISE-2 trial. They found that the post-operation hypertension is harmful. So many studies are conducted since then. In one study conducted last year in JACC, they used the goal as the mean arterial pressure 75 versus 60 per millimeter per mercury, but they found it's not reducing post-op complication between the two arms. And there's also one study in JAMA. They found an individualized intraoperation mean arterial goal might be helpful instead of the fixed goal for all patients. So let's take a look at the goal-directed therapy. First is to improve the global oxygen delivery. There are two previous meta-analyses conducted in 2013. They found this goal is inconclusive, and followed by another study published in JAMA in 2014, the optimized trial. They found that the DO2 more than 600 millimeter per minute per square meter has borderline reduction, as you can see on the right-hand side, the ranking value, the p-value is 0.09. The intervention group has less cumulative mortality than the usual care group. So interestingly, in this study, they also conducted another cumulative meta-analysis without any actually trial sequential analysis. So they concluded that it might be helpful after adding this larger study in the previous studies, and the meta-analysis indicated the favor to the intervention. Then let's take a look at the mean arterial pressure trial. First, the Fedora trial published in 2018. They conducted this trial among patients with low to moderate risk with elective measure non-cardiac surgery, and they found significant reduction in post-op complication using actually very simple goal, using like a fluid load, and then they use the stroke volume as the surrogate. Then lastly, they use the mean arterial pressure as their goal to start the vessel pressure. So let's shift gear to the patient-specific personalized approach. We want to individualize the assessment of cardiovascular reserve, like previously illustrated, and we want to predict volume responsiveness. We want to minimize the volume and use vessel pressure early. And lastly, we want to optimize resuscitation in different stage of circulatory shock. First, although the concept is clearly depicted a couple of years ago, the translation has been slow. In one finesse study published in 2015, about 7 years ago, they studied for a fluid challenge. They collect data from 2,000 participants. They found the practice is varies widely. And they also found there's no statistical significant difference between the groups which have a different response to the first fluid challenge. They sort of, scatter randomly, so people didn't really pay attention on the response of the fluid challenge. They just keep, giving fluid to the patient. So what can we use to do the prediction for fluid responsiveness? We all know this very basic figure table, and then we know that the previous concept is focused on either passive leg raise test or using the stroke volume variation plus pressure variation. The two main difference between these two methods is the need for heart-lung interaction, but the advantage of these two methods is there's no fluid needed to be administered to the patient. So this is a previous meta-analysis published in JAMA. So they found that the stroke volume variation has a relatively good positive likelihood ratio, followed by the IVC variation, the pulse pressure variation, and the best one is the passive leg raise test and the cardiac output change. As you may know, I think as you should know, that the positive likelihood ratio more than 10 or the negatively likelihood ratio less than 0.1 is the perfect method to use for either prediction or diagnosis. So let's take a look at the recent evidence of the prediction. So first is one study published in 2014. It's not really a recent study. They used the dynamic parameter as the goal to direct the fluid therapy. So as you can see on the right-hand side, the pool estimate gives us the evidence that this measure could reduce morbidity about 0.5 odds, and it also reduced the length of stay. And the other two meta-analyses published in 2017 and 2020 also have similar outcome. So let's take a look at the evidence for passive leg raising test. So in one of the largest studies published in the Annals of Emergency Medicine, this method reduced the renal replacement therapy. However, in the two meta-analyses published later, the mortality was not found to be different. But you can see in the picture below, there are still more studies needed to be conducted. As you can see, the trend is moving to the favored treatment group. So another subgroup of the sepsis patient, this one study published in Annals Intensive Care last year, actually 2 years ago. They conducted a multi-center prospective cohort study. Please pay attention on this study because this is not a randomized control trial. However, they found that using the mean arterial pressure, because this is a cohort study, people are not using the fancy hemodynamic monitoring on every patient. But they found that as long as you use the guidance, even just use a mean arterial pressure as the guidance, the guidance is independently associated with the mortality reduction. Then let's take a look at the attention to minimize volume resuscitation is to use vasopressor early. The classic approach is to use vasopressor after fluid completion. There's some observation study indicating that the delayed vasopressor administration is associated with mortality. And there are also some quasi-experimental study, mainly the propensity score matching study. They found that the early vasopressor are actually associated with less fluid and better survival outcome. But there are some inconsistent findings in the recent randomized control trial. In one of the studies published in the Blue Journal, in one trial conducted in Thailand, they found that early administration, the early is really early, is less than 1 hour of the administration of vasopressor, is associated with the better shock control within 6 hours. However, in another study published in the Annals of Emergency Medicine, the Collaborative trial just stopped early because of futility. They compared the liberal versus the early vasopressor administration, and they found that there's no difference. And in one last study published in New England Journal of Medicine, they found that the restriction of intravenous fluid is not helping the septic shock patient as well. So let's shift gear to use some goal instead of just use the fixed value to predict the fluid response. In one study published in Annals of Intensive Care with a preliminary cohort study, they found that the diagnostic shock index 2.5 is associated with death. So in another study, actually two studies published a couple of years ago, they used this ratio between pulse pressure variation versus stroke variation, and they defined that as the dynamic arterial reluctance. And they found that the normal tendency a dynamic or dynamic arterial reluctance is associated with fluid response. So in the study published in Critical Care, they found the area under the curve is the 0.94 is pretty good, and but the relatively small study. In another even smaller study, they found a similar area under the curve for fluid challenge. So lastly, let's take a look at the machine learning approach. I'm going to introduce you the Focus Continuous Vital Sign Index, the Hypotension Prediction Index, and our approach using heart rate variability and the PPG plus finger cuff and machine learning methods. So first is the one of the pretty old study published in 2011. They just used a very simple index using 5 vital signs, but they successfully, coupled with the nursing action, and they decreased 80% of cardiovascular insufficiency. So they use this BSI alarm system, and they just order some fluid resuscitation for the patient with the alarm, and they found it's successful. So I can only comment that the recent good study always come up with a clinical study instead of simply using either the fancy hemodynamic monitoring method measure or the machine learning approach. We have to see if the intervention coupled with this monitor really helps our patient. Then another study published in 2018 is the hypotension prediction index. So they use the arterial pressure waveform, and they use about 3,000 feature candidates among about 1,900 patient record with about 500,000 minutes. And the outcome is a lot, like 25,000 episodes of hypertension, defined as the mean arterial pressure less than 65 millimeter of mercury. And they use a very simple model as the logistic regression model, and they have a very good area under the curve that can predict the hypertension 15 minutes before it happened. However, they didn't interpret the model. Maybe it's some kind of commercial secrets. And after that, there are also some superlearner approach using better model. In one study published in anesthesiology in 2018, they also have very huge sample size as 13,000 patients, and the outcome is 9%, but the performance is not pretty good, because as you can see on the right-hand side, the best performance is about only 0.7 to 0.8 accurate under the curve. In another study published in JAMA in 2021, they used the short-term event prediction in OR, and they didn't provide the detail of their model, and they only provide the area under the PRC curve. For those who are not familiar with this kind of performance estimates, the area under the RC curve is actually stand for the receiver operating characteristic curve. As you may be familiar with, this curve is developed during the World War II, and this is actually the average between the true positive and the false positive rates. And if you do some internet search, you'll find that Wiki have the better illustration for the area under the Republic of China. In terms of the area under precision recall curve, this is a more computer science oriented the estimates. The precision is actually the positive predictive value in clinical medicine, and the recall is the sensitivity in clinical medicine or epidemiology. So you can probably have a feeling that the computer science folks didn't really pay attention on the true negative group, which is somehow also important in clinical or epidemiology. And this term is also have smaller territory in the Wikipedia. So lastly, I'm going to introduce you some of our recent efforts. This is a combination between hardware variability and the machine learning algorithm. We have pretty good area under the curve, or the ROC curve actually. So both on the derivation cohort and the external validation cohort in MIMIC-3. And this is under review in critical care medicine. We also take advantage of the PPG plus finger cuff plus machine learning methods. As you can see on these slides, we do the time series figure to evaluate the change of both intravenous fluids, inotropic agent, and some hemodynamic monitoring. So in our preliminary cohort in Chang'an ER, we want to predict shot index more than 1 in 20 minutes, 2 hours earlier, and using the 1-minute hemodynamic summary obtained from the ClearSight device. And we have pretty good area under the curve in the testing cohort. And we also have very clear, SHEP value plus to interpret the model. And this manuscript is in preparation. On the other hand, we also are trying different methods using a contactless PPG, and we can use that to obtain a pretty good heart rate variability, and the source code are available as well. So lastly, I want to have some recommendation for the future work. Is first to use a large number of subjects. As you can see in the previous studies, there are lots of smaller studies with less than 100 subjects, or with a very small number of subjects with many large number of measurement, which is not really good because somehow the subject has correlated measurement and it could overestimate the performance of the monitoring or intervention. And people always use different windows, such as 15 minutes, 2 hours. So it's difficult for researcher to come up with a conclusion of the either intervention or estimate. So the better performance might have a very consistent prediction window, but I will need to leave the decision to the society to come up with some consensus. And it's always better to elaborate the feature, either feature selection, feature extraction, and how you engineer the feature in order to convince the clinician how this model might be helpful in terms of using them on their patient. Lastly is always report with different evaluation matrix, not only one matrix. With that, I'm happy to answer any question that you might have. On the left QR code is my email. On the right QR code is actually the handout of the presentation today. Thank you.